Hi, everyone. I'm Kara Belt, the founder here of endpreeclampsia.org, which is the organization that runs our Facebook support group, Preeclampsia, Eclampsia, and Help Syndrome Survivors Global Support Network. I know that is a very long name, but we want to ensure that everyone who has any of those presentations of a hypertensive disorders of pregnancy can find us here on Facebook. Thank you to everyone who's joining us either via the webinar or the live stream here in the group. We have an amazing sort of end to Preeclampsia Awareness Month. Many of you know, either through this group or just through the media coverage, that last year Thermo Fisher Scientific was successful in getting a sFlt-1 PLGF ratio test through the FDA for use in pregnancy to help take care of and determine care plans for people who may or may not develop preeclampsia. And we're going to get to hear a lot more about it today. We have Dr. Rebecca Kahn with us, who is with Thermo Fisher Scientific, and I'm going to let her share a little bit more of her bio. And then we have Dr. Woodham, Champa Woodham, with us today, who's going to talk to you about how she's using this test in her clinical practice. So I'm going to let them both introduce themselves. They're going to have a chat about this breakthrough, especially here for women in the US, what you can take away from this to have great conversations with your care providers, and just have a better understanding of this test and its usefulness. And we're really super excited as an organization supporting all of you and all of those women around the world who may at some point have preeclampsia or who've had it in the past. It's a great tool to have in our tool belt, and it's a significant change in how we care for pregnant women with preeclampsia, hypertensive disorders of pregnancy. Such a change hasn't happened in 100 years. So we're really excited. Thank you both for being here tonight. Dr. Khan, I'm going to pass it over to you. And thank you again for being here.
Oh, absolutely. I'm thrilled to be here. My name is Rebecca Kahn, and I am currently a medical science liaison with Thermo Fisher Scientific. In my previous life, I was an OBGYN practicing. I practiced for 21 years, and then 2 years ago, decided to step out of the clinical arena and enter the diagnostic space. And it's very exciting to be part of the launch of this sFlt-1 PLGF test, because it really gives us something that we really have been lacking, and that's information about preeclampsia before it happens. And so for the first time, we can prepare instead of just reacting to what preeclampsia is causing. I'm going to turn it over to Dr. Woodham for her intro.
Thank you so much, Dr. Kahn. I'm Dr. Champa Woodham. I'm in Augusta, Georgia at the Medical College of Georgia. I practiced for about 10 years in the central part of the state at Mercer School of Medicine, and in 2022 was recruited to the Medical College of Georgia to start an MFM fellowship. And for those of you in the audience that know about the different types of training we get, after my OBGYN residency, we complete 3 years of high-risk OB training to be able to practice and take care of high-risk patients, both for conditions in mother as well as baby. So I'm in the process of starting a program like that here. And I was fortunate enough to get a chance to meet Dr. Kahn. And we are actually the first institution in our state that has implemented this new testing. So I'm super excited to speak with you all about it tonight.
Fantastic. Well, I guess to get started, can you tell us a little bit about what your practice is, the kind of patients that you see at Medical College of Georgia, on a daily basis?
Sure. So in the state of Georgia, there are actually 6 what we call regional perinatal centers, RPC for short. And those are 6 hospitals that have been identified as places where mothers can be transported to, or babies can be transported to, if there are high-risk conditions with a pregnancy. And so we are one of those 6, and we're actually the only, or the very first one to be a designated level 4 institution, meaning that we can take care of all kinds of moms and babies. We, of course, as a result, to answer your question of what types of patients we see what we basically label as the sickest of the sick. So these are moms and babies who have high risk conditions, and they could be as basic as a mother who's advanced maternal age, but they could be someone as sick as a patient who has HELLP syndrome, for example. And so for those reasons, we have a vast array of patients that we take care of, but I would say that for the majority, we take care of high risk pregnant patients.
All right, great. So just to take care of some basics, for any viewers that just are a little unclear on what preeclampsia is, could you just give us a little brief overview of the condition?
Yes, absolutely. So the easiest way to define it is a patient who is beyond 20 weeks of pregnancy and has 2 elevated blood pressures that are 4 hours apart. And by elevated, we're referring to the top number, which is the systolic blood pressure of 140 or more, or the bottom number, which is a diastolic pressure of 90 or more. And this would have to occur 2 times, at least 4 hours apart, to first satisfy the blood pressure requirement of the definition. And then usually what happens is it's elevated blood pressure with something else. So that with something else part is either protein in the urine, or a mother who has lab abnormalities or certain types of symptoms, like a headache that won't go away no matter what, pain up by the liver, which is on the upper right side of the belly, or changes in their vision, for example.
Are there degrees of preeclampsia?
Yes. So to step back for a second, a patient can come into pregnancy with what we call chronic hypertension. So chronic hypertension is a mother that even before 20 weeks of pregnancy has a either known diagnosis coming into the pregnancy, or their elevated blood pressures happen to occur prior to 20 weeks. Then the next step would be, once they are at 20 weeks or beyond, if they have just elevated pressures but nothing else, that technically is defined as gestational hypertension. Then if they have high blood pressures with the things that I mentioned just a minute ago, that would be preeclampsia, which is further defined as preeclampsia with severe features or without severe features. So there are certain types of lab abnormalities or symptoms that a patient can have that would push them over to the with severe feature classification. And of course, then we have the spectrum where if a patient does have a seizure, that would be called eclampsia. And then one of the most highest risk type of conditions a patient can get is something called HELLP syndrome, which is a condition where they not only have high blood pressures, but multiple lab abnormalities, and those moms are very, very sick.
So why is it important to diagnose preeclampsia as early as you can?
So the biggest thing is to catch this disease process in order to intervene as soon as possible. We all know that the treatment is proceeding with a delivery. However, you want to prolong a pregnancy as long as possible, as long as mom and baby are both safe at the time. And we know that the sooner we can diagnose this condition, then the OB provider has a heightened suspicion and can look out for those things that I just mentioned to see if there's any worsening in the condition of the mother. They might want to see the patient more often, sometimes 2 or 3 times a week, for example. And it really helps make a plan for that pregnancy for the provider as well as for the patient and her family.
Okay. Does it affect the timing of a delivery when a patient is diagnosed with preeclampsia?
Yes. So just like we were speaking of the different types of levels of preeclampsia, or what we like to refer to as hypertensive disorders in pregnancy, HDP, they, depending on what classification the patient has, that can affect the timing of delivery. For example, if a patient has preeclampsia without severe features or gestational hypertension, then a 37-week delivery can be reasonable. But if a patient has a severe feature, then a delivery at 34 weeks may actually be more reasonable for that mother to try to protect mother as well as baby.
Excellent. So what are some of the things that increase a woman's chance of getting preeclampsia?
There are several risk factors that have been found in multiple studies, and these risk factors include things like extremes of ages, so young women who are pregnant, like our teenage patients who get pregnant, as well as women that are advanced maternal age, which is defined as a patient who is 35 or older by their due date. Race also plays a role. We have found that our African American patients have a higher risk of getting preeclampsia. Patients who already have the diagnosis of chronic hypertension have an increased risk. And of course, patients that have had preeclampsia in a past pregnancy have an increased risk. Another factor which it does play quite a bit of a role in the southern part of the US, and in particular in my state, is increasing BMI. So for example, obesity, the higher the BMI, the higher the chance of getting a hypertensive disorder during pregnancy.
Right. So can you explain to our viewers how patients that have hypertensive disorders in pregnancy present, and what factors cause you to become suspicious that they might have preeclampsia?
So a lot of times patients will come in, for example, into the clinic for a prenatal care visit, and they may not actually know anything is going on, and we check their blood pressure, and that's when the nurse or the OB picks up the first sign. They see an elevated blood pressure. So there are some patients, which is what kind of makes this disease process more scary in some ways, where the patient may not feel anything at all, but it's the blood pressure that was the first sign. Then for our audience, you probably remember that when you went to go to your prenatal care visit, they got a sample of your urine. And what they do with the urine is they do like what's called a dipstick, and they actually measure the amount of protein. And if there's protein in the urine, that's yet something else that a patient is not going to feel herself, but the provider may pick up on. Now we have some folks that come in and say, you know what? I'm seeing spots in my vision. I'm having a headache. I've really tried all the things I am used to taking to try to relieve these symptoms, but it's just not going away. So a patient can come in with those types of symptoms, or pain in their upper right quadrant of their belly, for example. Those are the typical types of symptoms people come in. And then there's some patients who already had a diagnosis in the past, so they're very in tune with what to look out for, and they may have a blood pressure cuff at home. And I have had several folks that have come in and said, you know, Dr. Woodham, I took my pressures at home, I kept a logbook, and they're rising now. And so there are various ways of presenting. So it can be something where they don't have a symptom, but we pick up on it as a provider, to someone who knows their body very, very well and is the first one to tell me, hey, something's wrong.
So how often are patients affected by preeclampsia?
So, you know, it depends on what part of the country we're actually looking at. So in the United States, for example, up to 16% of patients have a hypertensive type of disorder in pregnancy, and that is the whole range from chronic hypertension to preeclampsia. And about half of those end up forming preeclampsia. Worldwide, up to about 8% have some type of hypertensive disorder in pregnancy. Now, if you really look at certain parts of the country, like where I am at in Georgia, our risk is much higher. So I like to tell folks, I kind of like to describe my day and say, well, in a day, how many of these patients do I see? And honestly, today was probably one of the higher number days. So we delivered 6 patients today, all for preeclampsia, all during the day shift. And it from the moment I got there, and typically, though, I would say every day we are working up or diagnosing at least 2 to 3 patients coming into the hospital. I'm not counting those folks that we already have a diagnosis and that are coming in for their clinic visits. So we, again, because we're an RPC, we have a higher volume of these types of patients.
Yeah. So, the US, you keep hearing about has more preeclampsia than other countries. And is there a reason for that?
There are several factors we can look at. We definitely know that, for example, obesity has become more of an epidemic in our country, and in particular, certain areas of the country have more patients that are obese. And as we discussed earlier in our conversation, that's a risk factor. In other countries that have lower risk, if you really look at those countries, there's folks that walk more often. They don't really have vehicles. Riding a car or riding a bus is not really an option for them. And so walking, they're healthier, their diets are different. The racial makeup of those countries may also be different. So there are various factors that will play into this. And one thing that my patients, at least I see with my patients, is a lot of women are waiting till later in age to get pregnant, right? Or later in life, because they may be in school, they may have a career that they want to go ahead and start before they start having children. And so that then, as we talked about, the extremes of age increases the risk of preeclampsia.
So what's the economic impact of preeclampsia in the US?
So, that data is what's really, really scary, is the fact that just pregnancy in and of itself increases or has related costs. But just looking at OB costs, this makes up about $2 billion a year.
Wow.
And that's a crazy number, right? $2 billion a year for dealing with hypertensive disorders in pregnancy.
Okay. So let's get to the nitty gritty. A new prognostic test was cleared by the FDA, as Kara shared earlier, and that is the Brahms-Kripter sFlt-1 PLGF ratio. And it can aid in the risk assessment of pregnant women with singleton pregnancies between the gestational ages of 23 weeks and 0 days and 34 weeks and 6 days, who are hospitalized for a hypertensive disorder of pregnancy. And it tests for, or it predicts progression to preeclampsia with severe features within 2 weeks of presentation. So can you explain to us why this is a welcome addition to testing for preeclampsia?
Yeah, so this is a very exciting test for someone like me who sees so many patients that have preeclampsia, because so far the American College of OBGYN has a standard of care of certain lab tests that we send on these patients, and that's blood tests as well as urine tests, and certain things that we look for and ask a patient about. Well, the issue is a lot of those things are not very specific. For example, the symptoms that we ask a patient about, such as a headache or any changes in vision, sometimes a patient just has that because they're pregnant. And so it's not as clear of a picture. And the same thing with the lab abnormalities. Sometimes patients have underlying types of conditions coming into pregnancy that have resulted in those labs already being abnormal. So then how do we tell if the patient has preeclampsia, or is that something that's part of their underlying condition coming into pregnancy? So the term we like to use is non-specific. Non-specific meaning the things that we already have or that we use currently as the standard aren't very specific to diagnose definitively that a patient has preeclampsia. It gives us a higher suspicion, and folks like me use the years of experience really treating these patients and diagnose these patients to kind of having that gut reflex of this is what we think is going on. So what's nice about this new test, the sFlt-1 PLGF ratio, is that it's complementary in so many ways, because it helps us further risk stratify these patients. So we still use the current standard of care based on ACOG guidelines, but by adding this test on, we can further try to decide or look at which patients we think may become sicker in the next 2 weeks.
Wow, that seems like that'd be very helpful. You mentioned the American College of Obstetricians and Gynecologists, or ACOG, and that they set that standard of care. Have they said anything about the SFLT1 PLGF ratio?
They have. So their statement really just restates the reason that the FDA did approve this test, that they do see this as a complementary test, and that they do see and agree that the findings from the study, which I'm sure we'll talk about in just a second, but there's a study called the PRECISE study. This is all based on, the FDA approval is actually based on. And so ACOG's statement further confirms that they also agree that that study's findings are showing that the higher the ratio, the higher the risk the patient has of forming a severe feature in the next 2 weeks.
So again, you mentioned the PRECISE study, so let's delve into that. And that study was published in November of 2022, and like you said, it was used to get this FDA clearance. So we know that this test has been used for many years in Europe. And why did it take so long for it to come to the United States?
So a lot of that has to do, first of all, different countries have different regulations and different governing bodies that make these types of decisions. And the studies that were utilized that led to the countries in Europe having this test for over a decade were in populations that are different from ours. And so what's so nice about the PRECISE study is it represented our population here in this country, and just the heterogeneity or the variety of different racial backgrounds and different ages, different areas of the country. So it was more applicable to our population, which is why it took so long. The other studies were not done with a population that's similar to ours.
That's understandable. So what was the main purpose of the PRECISE study? What were they looking at?
So the main purpose is similar to what you mentioned before, which is they were looking at this SFLT1 PLGF ratio to see, honestly, there were two parts. First of all, to figure out a number value that could be used to help predict those patients who might form a severe feature of preeclampsia in the next 2 weeks. And then the second part of the study is where they validated that number and looked at how accurate that value was.
Did they look at any other parameters other than just the development of severe preeclampsia within 2 weeks?
So the primary outcome was to look at the development of severe features in the next 2 weeks, but they also looked at what we called some secondary outcomes. And those in particular were adverse maternal outcomes and adverse fetal outcomes. So other things that might happen to a pregnancy aside from just forming a severe feature of preeclampsia. For example, a mother who ends up having a baby that's growth restricted, or the risk of an intrauterine demise, the risk of an abruption, which is where the placenta starts to peel off of the uterus earlier, prior to the time of delivery. So there are some other outcomes that they also looked at.
I believe they also looked at the time to delivery and
Yes.
if the patients delivered earlier, right?
Yes. And so they definitely looked at the value of the number and how that correlated with time to delivery. And since we're talking about that, I do want to let the audience know that what was so interesting is that they did note that the higher the value, the quicker that patient was actually proceeded to have a baby or to be delivered, meaning not that they went into preterm birth, but the fact that they got sicker quicker, and as a result, their provider ended up making the decision to proceed with delivery sooner.
So how good is the test at telling if a patient is going to get severe preeclampsia or not?
So that's some of the most exciting news from the study, is that it's able to detect up to 94% of patients, which is super exciting because, as we just talked about, the other things that are standard of care currently are so non-specific. And the other thing that's also important to note in a study like this is the negative value of it, meaning if it's a low value, how good is it at helping to predict that the patient won't get a severe feature or an adverse outcome in the next 2 weeks? And that was anywhere in the range of 96 to 99%, depending on what population you were looking at. So that's very exciting news.
So which population did it work better in?
It actually worked the best in the population when they broke it down of the African American patients.
Wow, that's important, with the high risk with race, but also the fact that the U.S. has not always made sure that our testing works as well in our Black patients.
Right.
So that's really exciting to hear that they looked at that as well. So you mentioned that this new test gives information prior to preeclampsia becoming severe. How's it able to predict who'll get sick when the other tests can only tell you that the patient is already sick?
So what it's looking at is there are two what we call biomarkers. So these are biomarkers that are created or made by the placenta in pregnancy. And it's something, these types of changes actually occur before the disease even starts. So the changes can be picked up on at an early gestational age, and one can actually potentially trend these values every 2 weeks, which they did do in this study for some patients, to see what happens to the values. And we see that whereas the other lab tests that are standard of care, those abnormalities occur once the patient already has the disease. These changes actually occur before the disease has even occurred, or meaning before the severe feature has even occurred.
Wow, that's great. Can you explain what makes a patient a candidate for getting a ratio?
Yeah, so right now the FDA approval is for patients who are hospitalized or in a hospital setting that are between the range of 23 weeks and 34 weeks and 6 days, that has a singleton gestation, meaning a pregnancy with just one baby, so not a multiple gestation, and who also already has a hypertensive disorder of pregnancy. And that's defined as a patient who either has chronic hypertension with or without superimposed preeclampsia on top of that, or a patient who just has preeclampsia, or a patient who has gestational hypertension.
So why can't you use it on somebody who has a multiple gestation?
Right now, that has not been validated, that particular data. That's not to say that one day we won't, but this study, when you start off doing studies like this, you have to really control the population to see what change in values occur. And we also have to take into consideration when you have more than one baby inside of you, these biomarker values can also be affected by that. And so to get data that is better to interpret in an initial study like this, they stuck to singleton gestations. But I do agree that there is a lot more data that we should look into, and further looking into other racial backgrounds, as well as multiple gestations and potentially different gestational ages aside from what we're currently looking at.
Could you share how the ratio has helped you in your evaluation and management of patients with hypertensive disorders of pregnancy?
Absolutely. That's the most exciting part for me, Dr. Khan. So I love talking about that. So, it's really interesting. We've been doing this testing since February, and we have gotten various ranges of test results. So let's first focus on the fact that we've had some patients that came back with really low ratios. And what's exciting about that, remember what we just talked about. The patients who are eligible for this test are in a hospital setting that have a diagnosis, and we're worried that something might be happening in the next couple of weeks. So sometimes those pictures are kind of muddied if the patient has an underlying condition that could have affected their lab test, the ACOG standard lab test that we do. Well, this ratio has been really beneficial, for example, in a patient of mine that had hepatitis, where her liver function tests were already abnormal. So how do I know that she's not having a hepatitis flare? And maybe her blood pressures were elevated because she was in pain from that, right? Well, when the ratio came back, it was 1, which is very, very low. So then I knew, okay, I feel comfortable now managing this patient with a hepatitis flare and not saying that she's about to form a severe feature in the next 2 weeks. Because remember, we just said it has a very good value in terms of the negative predictive value. I've also had the opposite spectrum where we have patients that come in with those symptoms and some questionable lab abnormalities, but we can't quite put our finger on it. And the value has come back in the thousands. And that has expedited in terms of, well, number one, we're following them much closer. We know how frequently we need to increase the number of times we're checking their lab values, their liver function, their kidney function to make sure that's not worsening. And though it's prognostic, it's not diagnostic, it is giving us the prognosis that something's going to happen in the next 2 weeks. And let me tell you, every single one of my patients that I've had so far, including one today, that has been in the thousands, has had their baby within 24 to 48 hours because something else happened.
So we never established what's the number that separates a high risk and a low risk patient, because you talk about 1 and you talk about 1,000. So where is that cutoff?
Yeah, so I'm glad you asked that. I just realized we never actually talked about that. So the number that we're using is actually 40. So if anybody less than 40 is considered low risk, and 40 and above is considered high risk. But as I talked about earlier, in the study that was used for the FDA approval, it showed that the higher the number, the higher the value was, the sooner the woman was going to deliver because she became sicker. So right now the cutoff is 40, but I want folks to know that as we're becoming more acclimated to this study, someone like me who's doing this, honestly, I'm sending about 2 or 3 of these a day at this point because of my patient population. I'm very quickly seeing that there's folks that are either very, very low or very, very high, but then there's definitely a group of patients that are above 40, but kind of close enough to it that I'm seeing they're not getting sicker as sooner, which is nice to see that the study results are actually correlating with what I'm seeing too.
Yeah, sounds great. So could you give us a patient example of how you've used this ratio?
Yes. So, obviously I'm doing this on patients that are in a hospitalized setting. They came in for a reason, right? Mm-hmm. So the example I used earlier of the patient who had the low value, I was able to manage her other medical condition. And then I realized that it wasn't a flare or some kind of preeclamptic type of presentation. And so that patient stayed pregnant much longer. Mm-hmm. Because if I had just used her liver function test, which is a gold standard, one of the gold standard tests that we do, one could have argued, well, they were so high, why wouldn't you deliver her? Well, before this ratio was something I could test for, I might have delivered her. And so what's so nice is that I bought time for that pregnancy and bought time for that baby to actually grow more inside of mommy and avoid a long NICU stay. Mm-hmm. And in the same way, because I'm able to look at those values that come back very, very high and of a heightened suspicion, I'm able to make a decision about delivery with more confidence. And honestly, my patients also feel very comfortable or more comfortable with the decision we're making if I'm having to deliver them early, for example. So even today, I had a patient that was 32 weeks. And she was like, I just don't want to have my baby. And I said, I really feel like this ratio is going to come back high. And she was kind of in that middle ground of she looked a little sick, but not super sick. But I was like, something doesn't feel right because she'd had preeclampsia in the past and her ratio came back over 1,000. And then it gave us closure to know we're making the right decision here. And she felt comfortable and her, baby's doing well. And I think it's because we caught the disease process before the patient got really, really sick.
So I've heard that this is especially helpful in patients with chronic hypertension because their clinical pictures can be a little bit more confusing than some other patients. Could you explain why that would be?
Yeah, absolutely. So Chronic hypertensive patients, during pregnancy, they may have just what we call an exacerbation or worsening of their blood pressure, but not necessarily preeclampsia on top of their hypertension. So that's really hard to pick up on, because how do you know that the blood pressure elevation that the patient is coming into OB triage with, which one is it? Does she just need a bump in her blood pressure medication? Or is she actually becoming sicker? And so this ratio is something that's very beneficial in those settings. It can help me, again, further risk stratify those patients to make a decision of how often I need to check lab values, how sick is this patient going to get in the next 2 weeks. And since we're on that topic, plenty of the patients that I've tested have been those chronic hypertensive patients that you're referring to. And quite a number of those, prior to the ratio being in existence, I think I would have delivered them a lot sooner. But when the ratios keep coming back on several of them of values of 1, 3, 5, all way below 40, I feel a lot more comfortable knowing that for the next 2 weeks, that the likelihood of them becoming sick is very low. And then I can prolong that pregnancy.
Does the ratio tell you when it's time to deliver the patient?
So no, I don't want folks to think that that's what this is doing. This test is more of a predictor and a risk stratifier. And I keep using that terminology because it's really what it is. It is giving the patient and the provider some idea, a glimpse of what could happen in the next 2 weeks. And that's what makes this test so exciting, is we haven't had anything like that before that helps us know in this short window of time, the next 14 days, could something happen? And so though it doesn't tell you, okay, it's time to go ahead and proceed with delivery, it gives you an idea of what the chances may be in the next 2 weeks. And that really helps in counseling a patient, counseling their family, and really preparing for whether the patient may have a longer NICU stay or not.
Mm-hmm. How are the patients responding to it? I mean, do they get what how it's changing things?
So at first, when we started doing the testing a few months ago, since it was so new, my conversations with patients were much longer, and trying to really explain and show them. I mean, some of my patients want to see the graphs and charts and all of those. And so I'm showing them that and explaining the test. And, as one would expect, a newer test causes patients to kind of question it. Like, I'm not certain. But let me tell you, once the patients have seen the test results come back and they see the correlation of, wow, I did get sick, or wow, nothing happened in the next 2 weeks, it's starting to really sink in. And I have had a few patients that have had the test done more than once. For example, I had a patient come in that we did the test on, whose ratio first came back at a 3. And I was like, okay, your risk of something happening in the next 2 weeks is low. I feel comfortable keeping you pregnant. Well, she came back to OB assessment 2 weeks later with a headache. And then her number changed to above 40, I believe was 53. And I said, okay, something has clearly changed here. We need to keep a closer eye on you. And then 2 weeks later, and at this point, she was with us in the hospital. She lived very far away. We were really concerned about her. 2 weeks later, she again just said, I don't feel right. Something's not right. Her blood pressure started to spike up a little bit more, and it came back in the 200s. Wow. And so then that told us, okay, this is real. This is happening. And you could see in her face that she had more trust in us, that we knew the latest technology, and we were utilizing the more recent tests to really know with better, I don't want to say certainty, but with more data, there was more closure in her case. Like, she felt more comfortable with our care plan. And she ultimately went on to have a baby that was healthy, had to stay in the NICU for a shorter period of time because we were watching her closer and caught the disease process before it got really bad.
It sounds like that was a real good way to make sure the patient was where she needed to be when she needed to be there, and not for longer than she needed to be there.
Yes.
Yes. So, I think this has been a wealth of information. May 17th marked 1 year since the Brahms-Richter sFlt-1 and PLGF ratio were cleared by the FDA for use. And, as we wind down World Preeclampsia Month, it's wonderful to hear that these biomarkers are already making an impact on the health and well-being of women and their babies in the United States. So thanks for sharing your experience with us. I'm going to pass it back over to Kara. I see that we've had some questions in the chat, and we'll let her moderate those as we wind down.
Yeah, I actually have, I'm going to take some liberty and put my questions at the front here. And we will get to the questions. Could you just take a minute, either of you, and explain in sort of simple terms what a biomarker is? Like Dr. Woodham mentioned, the placenta is showing these things. Could you just give a little more explanation on what a biomarker is?
Dr. Khan, do you want to take that, or?
Sure. So a biomarker is a substance from the body. In this case, they're proteins, placental proteins, that are markers of functions within the body, and that you can measure them to see whether organs are functioning the way that they're supposed to or not. And in this case, we're looking at, is the placenta functioning? Because we know that preeclampsia is due to damage that happens to a placenta very early in the course of pregnancy. You really start to see that the biomarkers, especially the placental growth factor, become lower between about 8 and 12 weeks in that pregnancy. And then the sFlt levels start to rise between 17 to 20. So, this is a process over time. And so those biomarkers really kind of help to identify when things aren't functioning correctly.
So you have these protein, these chemical signals in the blood, and then the test is a simple blood test to check the ratios. A simple blood test.
That's correct. It's a simple blood test. Right now, there's 2 ways to get it. It can be done as a send out. So if the lab does not have the device to run the test, it can be sent to one of the national labs that I'm sure people are familiar with, LabCorp or the Mayo Clinic labs. In that situation, it's a 24 to 48 hour turnaround time for the patients. If a hospital does bring the device into their facility, it is a much quicker turnaround time. By the time the blood gets drawn and the result is back, it's usually about an hour to get the result back in that situation.
So that's great to know. If the hospital that they're in doesn't have the equipment or the ability to do the test, it can be ordered and sent out to either the Mayo Clinic or to LabCorp. Many of us are familiar with LabCorp. They're kind of all over the place. So, but there's a delay in the turnaround time. Obviously, the specimen has to be shipped, the test has to be run, and then the results have to be returned. So that's really good to know. And that it's just a simple blood test. It's not something, extra scary that happens.
And if they're getting, if they're getting a ratio, they're probably getting all of the other blood tests as well. So it's
yeah, at the same time,
another tube of blood.
just another tube of blood. So we have some really good questions, and I think you probably covered some of this, but just to give some clarity. So Rebecca R asks, why is it required to have so many complications already that are clinically manifested in order to receive the test? And she said specifically when first pregnancy is such a risk factor. I'll let you guys answer, but I think I know the answer. It's how the study was done. It was the testing criteria, but I'll let you explain.
Well, a lot of it goes into the prevalence of a disease. If you do tests on people who do, on a lot of people who don't have symptoms of that disease, it's not going to perform as well as when you have a high prevalence population. And so with time, it may be that this becomes a test that is able to be ordered on more people and in different settings than just in the hospital setting. But for right now, yes, the the study only included the patients with the hypertensive disorders of pregnancy. There are some tests that are done in Europe using particularly placental growth factor in the first trimester to help predict who is going to get preeclampsia later in pregnancy. And the FNIH is currently doing a study to look at bringing that, or, how does that function in the United States population? It's anticipated that that study will be done in about 2 years, and we'll hear the results of that. So that may be something that we're seeing grow out of these biomarkers moving forward as more of a screening test. But for right now, we're really sticking to the patients that are, actively, potentially going to get sick. But prevention is very much something that is being strongly looked at in the United States.
Yeah, and from the patient advocacy viewpoint, some of the answer to that question is that I think people not in this industry have no idea how difficult it is to get clearance of a device, a therapy, whatever it is, through the FDA. And part of that is the FDA wants to protect people, and they want to make sure that people who receive a test like this, that the folks using the test aren't just sort of dismissing those who come back with that low ratio, that they're still watching them, they're still giving them the standard of care. And so in order to get something through the FDA, there has to be some merit to it. And so, we as advocates are very hopeful that, as this test becomes, more utilized throughout the country, that more studies are done, and then it maybe will get cleared to be used in other times in pregnancy, or in people that maybe don't have quite the same presentation. So it's not for lack of trying. It's to help people, keep people safe, and it's the first step, and what a magnificent step. And I know we've been trying to get this, and I say we, I've had really nothing to do with it. We've trying to get a ratio test for a decade, and you guys have really pulled through and made this enormous change, in addition to how preeclamptic women are tested and treated. So we really appreciate that. So hopefully that answers her questions. Let's see, we've got what is the device called? Can you repeat again? I know you mentioned it once, but it would be great to hear it again.
Right. So it's the SFLT1 PLGF ratio. There are some physicians who are starting to call it an SPR. It'll be interesting to see if that takes off. But for right now, that is what the name is. We're getting that question a lot, so who knows? Maybe it'll get a more fun name.
And then sometimes you'll see Brahms-Kripter in front of it. Is that a nod
right
to the
right? Brahms-Kripter
equipment?
is the equipment, and it's the platform that it is run on, which is a Thermo Fisher platform.
Yeah. Can you? What's the FNIH for our audience? Is it the fetal?
I think it's the Federal National Institutes of Health. I'm blanking on the F.
It's okay. I can't remember.
Foundation.
Foundation.
Yes, the Foundation for the National Institutes of Health. Sorry.
Very good. Thank you. Didn't mean to put you on the spot, but I couldn't remember either. So.
Any other time I could have gotten it like that, but
yeah. Jen W asks if there's a way to access the test off-label, and there are lots of reasons why you shouldn't or can't. One of those would be, getting the hospital to agree to that, the insurance costs, things like that. And I imagine, Thermo Fisher Scientific could not recommend that.
Right.
We're going to have to be sticking to that, to the FDA approval, the rules around that. But Jen, you can certainly talk to your own clinician about that. I don't know what the usefulness of it could be. I don't know that it would necessarily be predictive, because the tests haven't been run yet on whether it would be useful much earlier in pregnancy or not. So hopefully that answers that question. We're getting a few more questions in here. PLGF and F, I think it means sFlt-1, are not different in the first trimester between preeclampsia and non-preeclampsia. Indeed, sFlt-1 is lower in preeclampsia as compared to non-P. Sorry, I'm trying to get to the question. The difference starts, somebody is answering her question. So that's fantastic. Thank you, Shar, for responding to that question. We lost Dr. Woodham. Hopefully she'll be back in. Are there any?
Yeah. To address that, because somebody was saying that wasn't the right information, so I'm happy to address that. But PLGF levels in normal pregnancies are higher than those in preeclamptic pregnancies. So preeclamptic pregnancies, you see that PLGF becomes lower between 8 to 12 weeks, and it stays lower through the remainder of the pregnancy. sFlt-1 levels, on the other hand, start to become higher than in normal controls between 17 and 20 weeks. So the sFlt goes up and the PLGF goes down. And that's why you can put them into a ratio, and one number can quickly tell you how far off that placenta is from normal. Just to clarify that, since there was a little confusion in the chat with that.
Yeah. Jen W, certainly no, not second guessing. Good reason to access it earlier off label. Just we don't know that it works or will do what you need it to do, but that's a conversation you can certainly have with your own care provider.
Yeah.
Let's see. I'm looking at two different streams of questions here, so hang on here with me. Let's see. That's not. Had some other questions in here. One was, could this test be used for, so we have a number of our members, of course, who've had developed HELLP syndrome without, the hypertension beforehand, that kind of rare 5% of people that maybe develop HELLP syndrome without the traditional sort of blood pressure criteria. Would this be a test that might be used? Maybe Dr. Woodham could answer that. Would because we would normally see those clinical signs before that test would be used. So would that be used in a patient who develops HELLP syndrome without the blood pressure?
So right now, based on what the FDA approval is, we went through the different criteria, and right now the criteria does include a patient with chronic hypertension, with or without superimposed preeclampsia, gestational hypertension, or preeclampsia. So it does not include a patient that doesn't have elevated blood pressure, because they technically would not have one of those definitions. And so again, we're really sticking to the intended population that was in the study, not to say that these are not things that we can't look further into, like Dr. Khan was mentioning earlier. So whenever you implement a new test like this, you really need to be wise and careful how you do it, and you want to stick to the population that it was studied in. So that would be, again, considered off-label use. And so the FDA approval, of course, is not for off-label use at this time.
Very good. Yes. And so I think that, is an important point to kind of reiterate. This test isn't a rule out, or, we're using standard of care, physician's judgment based on experience and training. And this is another tool, right? And it's a fantastic tool, because there are some clear cutoffs and ranges that can help provide guidance on the care plan. But it doesn't necessarily give you, just by that test alone, a diagnosis that then gives you, a delivery time frame. It is, there's still care provider, standard of care, and care provider experience involved in using this test to determine every single individual patient's sort of care plan going forward. Would that be correct?
Yeah, I mean, it's really to risk stratify. And I think one of the points I want to make, that I make to my patients, is part of doing this webinar also for everyone tonight is to really empower women. I mean, that's a big thing that I talk about every day. This is a study, a test now that you know about. And I think it's important for a patient who's pregnant to advocate for themselves. And if they fit the criteria and they see that they're, if they're going into the hospital and they have those things, they have a singleton pregnancy, they're in that gestational age, and their doctor or their care provider is concerned about a hypertensive disorder, this is a test that that provider may not quite know about yet, because it is still on the newer side here in the US. And so what another big point I want to make from tonight is making sure that we empower women to ask about this test and ask their doctor or their care provider, do you know about this test? Is there something that I can have done? A lot of times that'll open the door for more conversations and for that provider to reach out to an MFM like me or to someone like Dr. Khan to ask about the test. Where can they get it done? Who they can send the blood sample to? So that's, I think, one of the bigger points I want to make today, aside from just teaching more about the test.
Dr. Woodham, what if you weren't utilizing this test already and a patient came to you, what sort of like dialogue or script could a patient use to sort of ask for that would I think a lot of times our members or patients they don't want to offend their care provider. They don't want to, and they maybe don't even feel comfortable asking because they're not exactly sure how these things work. And now they'll have so much more knowledge after today's webinar. What would you suggest? How should somebody approach their care provider? How would you want to be approached for something new like this? And I'm sure you get approached all the time about lots of things that people find on the internet. So what could somebody say to their physician to inquire about this?
I think one way to approach any care provider with a question like this is to say, I'm just really concerned about my health and my baby. And either, for example, for this test, to say, I was on a webinar and I heard about this new test. Do you know anyone, or do you know a high-risk OB specialist that we could maybe talk to see if this is something that we can draw, and just kind of get their wheels turning, right? I mean, that's the first step. And I don't know many physicians that are going to get offended if you ask in that manner of like, I'm just really scared and I'm really worried and I want to do anything I can for my baby and for me. Do you know about this test? And sometimes a provider will say, yeah, I've kind of heard about it. I mean, I can tell you for me, when I've had OBs call me and say, my patient was asking me about this. Do you know anything about this? And I'm like, yes, I do. And then that's how the conversation starts. And I say, I can put you in touch with someone from Thermo Fisher. I can let you know about the labs, where the send out labs are done. And that's really all it takes. I don't be afraid to ask your provider questions. You watch out for your own health. Like, it's very, very important. And I wish more people would do that because it really helps educate us. But I think you have every right to ask, can I have a consultation with an MFM, which is a high-risk OB provider, which is what I do, and just run this by them and see what they think. And most OBs have an MFM that they send their high-risk patients to. So that's one way of kind of putting it on somebody else to kind of talk to them about it.
And my job is to educate physicians about this test. And so I love it when somebody shoots me an email or, gets a hold of my number and gives me a call saying, okay, tell me about this test. Tell me how this can help me. I love it. So I would be more than happy to talk to any physician who needs more information.
And I imagine even referencing the Precis study could be, I would think a doctor would be like, study, oh, this person's, talking about science. And that might trigger them to, maybe after clinic is over or whatever for the day, go do a little research and then, maybe reach out to a colleague or someone, at Thermo Fisher who, could give them more information. So I think I find that that's always helpful when I come from a point of data or science, like, oh, this person's paying attention, it's not just something they found on Google. And they seem to be, more interested in having that discussion. So I appreciate that, advice as far as approaching your physician. Certainly we do want to empower our patients to, I think, just have really open and honest conversations with their care providers, and that includes, getting the answers to the questions that are on their mind. So I think, let's see, we're pretty much done with questions. There are a few questions for those of you who ask questions in either of the groups that aren't directly related to the SFLT 1 PLGF ratio. We will follow up. One of our admins or moderators will follow up and answer those questions. We have resources for all of those questions. So I'm really focusing in on the ones that are specifically on this topic. So I think we discussed, they can't really get this test in their normal OB office. It's gonna be a hospital setting, or with their MFM, which is, typically hospital related. Are there any other points, and this is maybe for Dr. Khan, any other points that you would like just our audience to take away today from this webinar?
I think hope, right? Hope that things are getting better. It's nice to be in a world where women's health is getting, attention that it deserves. As you said, this is the first advance in preeclampsia care in 100 years, and that speaks, loads to what that need was. And so I think just knowing that, we're not done working towards, better care and better diagnostics for preeclampsia. And, I don't think that we'll stop until nobody has preeclampsia. That has to be the ultimate goal.
Thank you. That's a fabulous way to wrap up this webinar here today. Thank you both so much. I know you're both very busy, for taking your time out to come talk to our members and everyone, who is not yet a member and may develop a hypertensive disorder, a pregnancy at some point in the future. We'll get this out on the World Wide Web for others to share, but we really appreciate just sort of the patient-centric, patient-friendly conversation about this test and how people can access it. There's been a buzz for a while, since last May, and so we're really excited to wrap up this World Preeclampsia Month with this conversation, this innovation that the likes we haven't seen in this country, at least for over 100 years. So thank you both for your time. We appreciate it and your expertise. Have a great night.
You too.
Thank you.